Hi, everyone, and welcome to the continuation of our WTF, What's the Future with InBrace series. Today is a study club discussion around InBrace's superpower, specifically how InBrace can outperform other modalities. I want to thank everyone for tuning in and for your continued support. We had a one study club session on Tuesday with great panelists, some that you'll see again today, great attendees, and even more case studies. That session went from 90 minutes to 2 hours long because of the great discussions and because of the great case studies that were shown. We have even more today, but we do want to be prompt on time, so we will end this at 90 minutes. If we don't get to everyone on the panel, that just means we need to run this again, which we will do. Today's moderators are myself and Matthew Wang, Head of Business Development and Strategy. As always, please feel free to use the chat feature to ask any questions throughout the case discussions. You can also submit questions through the Q&A so that we can ask on your behalf, and all our panelists can see the questions as well if you have a question while they're presenting, and they can type to you after they're done. With that, we're going to kick it off. As I mentioned, we're here today to talk about InBrace as a superpower. We've spoken a lot in the past from our marketing and our webinars about what's in it for the patients and the consumers. But in 2024, we're going to dive a little bit deeper and talk about what's in it for you as my colleagues and as orthodontists, and why it's in your best interest to treat more with InBrace. There's a lot of narratives and myths out there about lingual systems, built up scar tissue, and fear, so to speak. And at times, InBrace can get bucketed into that. But we live in a world right now where we do not want InBrace to be the best kept secret. We want you to leave here today thinking, man, InBrace can. It's awesome. I didn't know, but now I do, and I want to give it a go, or give more a go if you're already a provider. So in the spirit of celebrating our wins and being an orthodontist myself, I get it. We need modalities that fit seamlessly into our practice. And many of you on this call know for the last two years, we've had our TIS teams in your office's chairside. And we don't like to drink our own Kool-Aid. So with our TIS team, we've given them stopwatches so they could time all the appointments that they've had. And you can see that our national averages for appointment times fit within those standard appointments. The check-ins and adjustments and working appointments are 30 minutes. Your fittings and bondings fit within 60 minutes for single arch. And within our in-studio clinics, we set out to prove that our product and our innovations will work and fit within this time slot. We average about 43 minutes per fitting. So we know that it can fit seamlessly and integrate into your practice. With that, here's our panelists that we have. These are our colleagues who have volunteered their time to come and show you exactly what InBrace can do. Because when you ask any of these panelists, what's the future, they see and believe that that is InBrace. They want InBrace Nation to grow. The perk of it is you can't see it, but again, InBrace should not be the best kept secret. They want their peers, that's you, to start doing it. And if you're not, you're only holding yourself back from growing and innovating. So again, as mentioned, this is a study club discussion. So ask away all the questions you may have, and we'll kick it off. Dr. Sarah, I'm going to get started with you.
Hi, guys. I practice in Pensacola, Florida. I'm Sarah Howell. The first case I have is Talia. She's a 21-year, 11-month-old school teacher. Her chief concern is crowding, and being young, her main concern was having braces as a young adult. She didn't want anything showing, so aesthetics obviously is her main concern. She also didn't want to have to take aligners in and out while she's at school, while she's teaching in front of her kids. So InBrace was the option for her, and she was actually my first InBrace patient. So she was my kind of guinea pig. But our goals for her were to alleviate crowding, optimize overbite overjet. Her lower incisors were retroclined, but that's an easy fix as we alleviate her crowding, and to improve her mandibular midline. So the reason InBrace is kind of a win for her is she's young. She doesn't have to worry about compliance with aligners. And then I was personally worried about speech with her being a teacher, but she adapted pretty quickly. She was pretty motivated. And we'll go on to look at her case. So she was pretty crowded on the lower. This is actually her first appointment back with these progress photos. So this was kind of like my wow photo. We didn't have room to put the brackets on her lower threes and lower left one and lower right two. So we had to keep a lot of brackets off at first and directional bond the wire. So she got the specialty wire at first on the lower, and then we started in Smart Wire 1. Just some considerations for her smile design. We had to do quite a few decompensation root tips because of her mesial ins, mesial outs on her upper incisors. So Other smile design considerations, I mentioned severity of crowding and starting with that specialty wire. This was her 6-month progress photo. So she got her InBrace bonded in December of 2022. And then this is June of 2023. She's in SmartWire 2, upper and lower at this point. And basically at this point, we're liking how everything looks, just some small rotations on her upper incisors and bite settling. I started to notice a little bit of a class 2 canine on the left side, but we just bonded some buttons on upper and lower fours and settled her bite. And that's her finish slide. So this was a year of treatment. She had 11 visits, including her records, consult, scan. We do that all at the same visit. And then she also had 2 SOS appointments. So really, it probably should have been 9 visits, maybe, or maybe 8 visits, but I was really happy with everything. Her brother was a prior patient of ours, so that's how she found out about us. And she kind of held off on doing treatment because she didn't want traditional braces. And so we made the InBrace option pretty affordable for her being a teacher. So she was elated with her experience. Conclusion. Okay, so things I would change is I probably would put more overcorrection in the root tip that we're putting in to compensate for our mesial in and out. That's the reason why we ended up doing the DE, is because we weren't happy with root angulation. So I would increase my compensation for that. Again, this was my first case, so it kind of boosted my confidence a little bit with InBrace. I wasn't sure what to expect. I'm confident with class 1 crowding cases, so maybe I'll try some AP crowding cases in the future and see how that goes. But that's my case number 1, Talia.
Awesome. You did great. So when you look at this case, what was your initial reaction in terms of the efficiency of the InBrace compared to what you've seen and what you're familiar with other modalities in the past?
I was pretty impressed because with only we did 3 wires on top, 4 wires on bottom, including that specialty wire. We really didn't have to repo any brackets or anything like that. So it was extremely efficient. This case probably would have been at least 12 to 18 months in braces, maybe longer. Invisalign, about 12 to 18 months, depending on compliance. So if she wasn't compliant with wearing her aligners, I've seen it stretch out longer than that. So I was pretty happy, and she was pretty happy with it too.
And
it made it really easy. It was very little doctor time in this case.
Awesome. And how much time was it total again with InBrace compared to?
It was 12 months.
12 months. Awesome. Cool. All right. Go ahead, Dr. Oldham. Just go quickly introduce yourself. How did you become an InBrace provider? How long have you been an InBrace provider? We'll go ahead and give you the floor.
All right. Well, my name's Cody Oldham. I'm a solo doc out in Midland, Texas. Opened my practice in 2020, and we started InBrace about 3 months into practice. So we've been doing this for a little over 3 years. We went through all the fun of Gen 1 and had a lot of learning as far as that went, but we were absolutely loving Gen 2. So I'd like to show you a few things that we've done with Gen 2.
Awesome.
All right. Well, let me tell you a little bit about this patient. 66-year-old patient. She came in because she wanted to be able to clean her lower teeth. So, of course, when she comes in, she's heavily restored. We've got crowding. We've got open bite tendency, class 3 on one side. We've got a bridge over there, lower right 5 to 7. We've got all the things going on. And, of course, she would like to have an invisible option. With that bridge down there, I prefer to do something digital so that I can try not to move that. And that's why I started looking at doing InBrace. That, and of course, Invisalign, if you've ever worked with a bridge, you have to worry about it going off and on, off and on. And you can debond bridges and crowns as well. So we talked to her about Invisalign. She jumped on board right away. And we started discussing taking out a lower incisor in this case. And one of the cool things with InBrace is you can say, I want to take out lower left 1. And then you can see it and you can say, what does it look like if I take out lower right 1? And you can actually go through all these simulations so quickly, and you can find whatever's going to work best for that patient. So in this case, we decided to take out lower left 1. So this was bonding. Right off the bat, you can see that span where that lower left 1 was a little bit too long for that wire to reach. So like everything in orthodontics, you just kind of have to MacGyver things. So we just put some little buttons down there, put a little power chain on the bottom there to get them a little bit closer. 3 weeks later, she comes back in and we're able to stretch that wire and click it in there in a little 5-minute appointment and just keep moving forward. You can see that we just direct bonded that upper right one at this time, and we were able to get a bracket on it the following visit. So, and kind of go to the next one. So now 4 months later, we've got all our space closed. And we're just ecstatic. The patient is so happy. Of course, we knew from the beginning, we had this bridge, we had all these other things going on, that we're going to have a compromised occlusion. But our goal was to get some overbite, to get straight teeth, and just to aesthetically improve everything. So all that we did in this case was we did upper IPR to help control all the flaring there. And then on the bottom, of course, we removed the one tooth. We did add some extra root tip there, down there to the one and into that lower left two. I actually repositioned that lower left two at this time so we could get some more mesial root tip. We added some triangle elastics there, went to DE wires too, and this is where we're at now. We just scanned here earlier this month. So about 10 months in, very straightforward. And she's already here. And I do not believe that I would have been able to do this with labial brackets in this amount of time while still maintaining these really customized arch forms here, because we had to maintain this bridge on the side, and just keep it all together there. So we did a DE at this point, and we're going to do a little bit more touch-ups, but she's just ecstatic. She loves it. My wife hates that I put silver buttons on these patients, but honestly, they're more comfortable than the ceramic ones, because I tend to have more complaints now with Gen 1 about my buttons for elastics rubbing the cheeks than I have the tongue being upset by the brackets on the inside.
Right.
Which really is amazing, because anybody that's done Gen 1 knows that soft flow is your friend when you're using that appliance. And really, I don't have to use it with this appliance, which is outstanding.
Right.
But she's ecstatic, and we're loving it. And this has definitely given me a lot more motivation to take on bigger cases with InBrace. So hopefully in the future, we've got a couple InBrace surgery cases that are in the pipeline right now. I'd love to show you those as we get going forward. But,
that's right.
So that's kind of a more involved case. Let me show you a couple just little quick hitters that we also do here in the office. So this is a patient, 2 kids in phase 1 in the office. You can see up there in the upper left, she's got this lower bonded retainer that's held on since she had braces, but it was only bonded to the lower 3s. That allows that spacing to come back on the front. She thought that Invisalign was disgusting, coming in and out of the mouth. So I showed her InBrace. Bottom left is initial bonding. Top right is 6 weeks later. Bottom right, so that's wire 1 up there in the top right. We placed wire 2 at that point. 8 weeks later, we debonded and placed a bonded retainer. 14 weeks, basically 3-4 visits. She was done while she was still just coming in on regular visits with her children for phase 1. That would not have happened with another appliance. With Invisalign, maybe somebody could get that done in 14 trays, but you've got lower canine rotation you have to take care of, and crowding, and the crowding on the lower 2s, spacing between the lower 1s. And I bet you it would have taken longer, if nothing else, just having to rescan and give more aligners later. So like I said, we're excited about this, and I thought that was pretty quick. So, all right, let's go to that next case. This was actually my first Gen 1 case. Actually, pardon me, this is the first Gen 2 case. We had done a bunch of Gen 1, and actually our rep came out for lunch. This was the first patient that came in after lunch for consult. Previous Invisalign patient. Clearly, she didn't like her upper incisors. There's actually a torque differential on those upper incisors. And really what needed to get done was we needed to get buccal root torque on that upper left 1 and intrude it, which really work against each other with Invisalign. If you're going to intrude, you're naturally putting in that palatal root torque. So this would have been very difficult with the aligners to get there. But if you look, that's the start on the left. Top right is 5 weeks later. That's the first visit she came back. She said, "Am I done?" And honestly, we probably could have been, but I really wanted to work and see what we could do with that torque. We actually went wire 1, wire 2, wire 3. She let me do a DE to keep working on the torque there. And I believe if I look at that upper left one, where it started and where it finished, we did get some buckle root torque on that tooth. Her favorite food was ribs, and she ate them the entire way through treatment. Never broke an incisor bracket.
That was her biggest concern.
Yeah, literally, that was her biggest concern was, can I still eat ribs with these? And I said, let's do it. And honestly, with the new bonding pads with Gen 2, especially versus Gen 1, we just don't have many broken brackets. And honestly, it's so much easier now to deal with it because we section, we make single tooth bonding trays, and honestly, my assistants rebond these brackets for me if something breaks. So it makes it really, really smooth. And then I've got one more quick case here. So this one was kind of fun. Grew up with this lady. She's about a year older than me in school. You can see she's missing a lower incisor. She's got upper and lower spacing. Came in. She said, I want to get these spaces closed. I don't want braces. She came in thinking Invisalign is what she wanted, but deep bite, spacing, Invisalign, already don't have any torque on your teeth. That's not the route that I wanted to go. So we talked to her about InBrace, especially after we had already seen some space closure with some other cases. And really, the way that we worked forward was it was lower wire 1, lower wire 2. Then we bonded the upper, went to upper wire 2. And then you can see the next photo is where she was. Just changing wires, no auxiliaries. And this is where we rescanned. She's still got a little space on the lower right 3-4. And you can see that even with that space closure, we haven't made her any deeper, which is really pretty impressive. Hindsight, I probably could have gone in and intruded the lower 3-3 more. And I know that this is a unique case because we're missing a lower incisor, so I got some artificial overjet, which helped here. But she's ecstatic. It's been very, very smooth. And in less than a year and just a few visits, she's gotten from there to here. So InBrace is quickly becoming a big part of our practice. And I think it's pretty awesome. So.
Awesome. Well, you do have a question. You do have a fan. Just kidding. What is your bonding protocol, and if this overjet can be improved so quickly with InBrace? And I think bonding material was the question.
We do basically whatever InBrace told us to do. So everything tends to be lower. We'll do lower than upper, especially if it's a deep bite. And I usually will do lower, get them into wire 2, and then bond the upper at the following visit, whatever that timing looks like. Usually 6 to 8 weeks is where things kind of roll out. And then, of course, we're etching, bonding with the Sure. And then I think we still use the light bond because that was the original that y'all said to use. I know that's changed now, but to go to. Oh yeah, we use the hair dryer. Thank you. We air dry. So basically, we just go through the steps that InBrace provided, and it's been real straightforward. My staff loves it because they're able to just run through it very quickly, especially once the plier to open all the doors was provided. That's just streamlined everything. These visits, we still for a long time had them on longer visits, like 40-minute to 60-minute visits, because with Gen 1, it might take that long. Now, these are visits that we make up time in our schedule because they're in and out in 10 or 15 minutes to just go to the next wire. And it's a game changer.
Love that. All right. So thank you so much, Dr. Oldham. Who do we have next, Tara?
We've got one more, Dr. Sarah's case, second case, and then Dr. Horsey up.
Okay, so this is Cohen. He is a 15-year, 11-month high school sophomore. His main concern is spacing, and he's also got a little bit of a deep bite. He chose InBrace for aesthetics. His mom didn't think he'd be compliant with aligners, and he didn't want braces. He didn't think he's going to get a girlfriend with braces, so he chose InBrace. I was a little worried about how a younger patient would do. He was my first teen patient, but you'll see that he's doing great in them. So let's see. Smile design for him. He had a bit of space to close, not a massive amount, but I was worried about torque control, and just initially, in my mind, I'm thinking, okay, braces, if I put posterior buildups on, I'm making the bite deeper. I use anterior bite ramps for braces cases all the time. So I was a little worried about how this would do, because this was my first deep bite case. But if you go to the next photo slide, this is his first appointment back. Literally, it opened up his deep bite so quickly. I'm worried about now having an anterior open bite tendency. He's a little bit class 2-ish on that left side, so we added in some elastics for him to wear, like a class 2 box. But again, if I were to redo this smile design, I would build in more lingual root torque on the upper anteriors. So we put him in SmartWire 2 on this day. He came in after SmartWire was one was activated. Also in his smile design, we put in a lot of mesial root tip on his upper ones because of that space closing. So we wanted to kind of make sure those roots converge together as we're closing that space. The next picture. So here he came in while he was in SmartWire 2. And then we put in his DE SmartWire 2. So in his DE, I incorporated a lot more lingual root torque, and I'm also extruding his upper ones and his upper twos just a little bit to give him a nice aesthetic smile line instead of that kind of flat smile curve he has in these photos. But you can see that class 2 box that he's been wearing on that left side, and then a regular class 1 box on the right side. So this is where he was in October. So he should be coming back in soon, and I'm hoping we'll be able to finish him up pretty quickly. He started this summer. So if we can get him finished up in less than a year, that'd be great. And he didn't have to suffer with the anterior bite ramps that my braces patients do. Let me go to I have a cheat sheet over here. So yeah, traditional braces, this is at least probably 18 months for me. The nice thing with InBrace, as you all know, we can work in all 3 planes of space at once. So you saw how much space closure he got in just that one appointment. So I don't have to work up to a heavier wire to start closing space. They're seeing that immediate result. And his parents were very impressed. So they've praised everything about InBrace so far. I mentioned I would change more overcorrection in the lingual root torque in my initial smile design. I wouldn't have overcorrected his bite opening as much, maybe for an adult patient, but for a teen, I wouldn't do that in the future. And then this case has kind of taught me to trust InBrace on younger patients. So last week, we started another teen case. So I'm still a newbie into InBrace, but so far it's going well. He has had no bracket breakage, no emergency appointments, which is interesting for a teenager. So that's been going well for him. And this is just learning on this case. It's giving me more confidence in using this for deep bites, because I was worried about quite a bit of bracket breakage or deepening his bite with those posterior buildups. And that's pretty much all I have. If anybody has any questions on that case.
All right, we'll give it about 5 seconds in the chat. If there's no questions, we're going to move on to Dr. Horsey. All right. So we'll go to Dr. Horsey, and if there's any questions, we'll bring it back to Dr. Sarah. Dr. Horsey, thank you so much for being on the call again today. You were on Tuesday and you killed it. You were one of the, we've heard so many good stories from you. And anyways, without further ado, I know you got a lot of cases, so we'll let you go ahead and get started. Tell us a little bit about your background too with InBrace and how long you've been with us.
Yeah, so I started with InBrace in 2017, training and starting some cases then, and then really started to ramp up 2019, 2020, doing lots of different types of cases to make sure that we can offer it to all of our patients by just learning with Gen 1 and now growing with Gen 2 in our practice. Our team loves it. They've got great training from Aaron, which a lot of y'all know, who's amazing. And all the staff and all the people at InBrace are super responsive. to helping you grow, helping the system grow, listening to their end users, and making sure the patient experience is the best it can be too. So it's really a great system, not only because of what it does, but the people behind it too. So, but yeah, we've got about 300 plus InBrace cases under our belt so far, and really highly recommend getting your team trained. And then also the other pearl is take photos every visit or as many visits as you can as you're learning to see what the system's doing, how quickly it's doing it, how to work your overcompensations, listen to your smile design. Listen to Dr. Tara. She's amazing when it comes to smile design. In order to avoid, DEs, extra DEs, longer treatment. Because if you really treat the system well, it'll do well for you and your patient too. So awesome. So I've got a couple cases to show tonight. So first case, 48-year-old male, obvious clinical problems and chief complaint are his anterior open bite, posterior open bite, severe spacing, both upper and lower. He's got a little bit of contact basically on his lower 8s with his upper 7s is where he's primarily biting at this stage. So basically he wanted InBrace because he works in the local school system. He was going to be embarrassed if he had to wear braces on the outside, and really wanted to fix his teeth. Really nice guy who smiles a lot, but would definitely feel more confident if he could smile with a little bit more aesthetic smile. So basically that was InBrace's key for him choosing that system as well. So this is his initial photos. Between here and the next photo, we did have his lower 8s extracted to help with his space closure. But our first progress photo is at about 5 months. This is with his SmartWire 2 in place, basically closing his space, closing down his bite anteriorly, and basically setting him up to get his posterior bite closed. Next photo is us doing his elastics. So we used our 2.5 ounce elastics, his triangle elastics, to help level the bite and get his teeth fitting together well into a nice occlusion, a nice stable bite at 12 months. So pretty much system-wise, if we were to even think to use something like aligners for his case, even if we had to use it, it would definitely have been a trial with the space closure, the closing down the open bite, the lack of posterior teeth, elastics to have to run, compliance, everything like that would definitely drive us to be a much longer, more difficult situation. And I probably would definitely advise the patient not to do aligners, in my hands at least, in this system. Traditional brackets, again, like we had talked about, you're getting all your movements with the same wires, so you're not having to work up through a wire sequence like I would have to use of a 14 9 tie, 20 9 tie, 17 25 before you even get to the space closure. So you're actually getting that closure from day one, which is awesome. So your wires are working for you, and you're not having to put so much work into your wires to get them to work. So, and this is a Gen 1 case. Gen 2 obviously is a more efficient, effective system that you can use and take advantage of a lot of the added benefits of Gen 2 when it comes to the robust system, as well as the hardiness of the wires and the bracket, especially the bracket pad and the bond strength that we talked about. So it's definitely, and you can use a little bit heavier elastics now on Gen 2. So Gen 2 is an even improved version of what we would do in this particular case.
Before you go on to the next case, you did have a question come through. How did you level the mandibular right posterior without brackets or wires?
Let me take a peek at that. The mandibular right posterior.
Yep. And as you do that, you got a lot of wows and woo-hoos as from.
Oh. We initially had a bracket back to that lower right 7. We did have some breakage. So towards the very end, we just left the bracket off at that stage because it just wire span wise and bracket wise, he was having some breakage on that gold crown. But yeah, we used an extension of the wire back there initially until we just kind of felt we didn't need it anymore. And the breakage was just too much of an annoyance in the Gen 1 that we just left off.
Thank you.
If that answers or doesn't answer that. All right. So second patient. So this patient came in, his brother was a patient of ours, and his brother actually had InBrace as well. So he's 18, about to graduate high school. They already did, but they were planning on taking a cross-country trip after he graduated. Basically, he wanted InBrace too because he didn't want anything on the outside showing. And he knew he wouldn't be compliant with wearing aligners at that stage. And he saw his brother go through treatment and was impressed and wanted to do the same thing. So his problem list, obviously, is his anterior crossbite, an occlusal cant. We have some torque issues when we talk about our incisors. and we have crowding on both the upper and lower arches. So this case with InBrace is going to be an easier case because, again, you're getting your torque, your alignment, your correction of your cant all within the same wire. Even though you can't bond all your brackets at the same time, as you'll see, we'll be able to add brackets to blocked out teeth as we go along. So this is why he chose InBrace for us. So we'll go to our progress photo at 7 months. So this is when both the upper and lower are both bonded. We have correction of his crossbite in the anterior with the correction of his torque on his incisors. And then this is Gen 1 too again, but and his lower left 2 area, we were able to bond that bracket at this visit. And then from here on, that tooth was able to track well into place from this visit to the next slide and move into place well in order to kind of get his final correction of his lower left 2 area. So a little bit of IPR built in to help with that, but a pretty good correction of his occlusal cant as well as his anterior crossbite by using InBrace in his case. Again, aligners would have been a little bit more difficult when you're talking about incisors, and especially in that those lateral and central incisors, making sure they track well, especially with compliance being an issue. Brackets, you would have had to avoid certain segments of wire as you're moving along and then working up to your rectangulars to start to express your torque. You would have to do pretty creative bracket placement to make sure that you're leveling, or maybe indirect bonding if you use that, and make sure that you're leveling across there for him. Elastics, I do not believe we used elastics in his case as far as to help with this case. Oh, sorry, I saw the chat come up, so let's answer that one. But yeah, he's pretty much finished out and in retainers at this stage shortly after this visit. Again, another Gen 1 case. So could be more advantage on Gen 2. You might be getting a little bit more posterior torque expression and a little bit quicker alignment of those lower teeth and just a hardier system as far as avoiding breakage and everything. And that's it for that case. Cool. Let me check to make sure there's any questions on the chat. Elastics, I already talked about that. For his, we did not use it though. All right. And our third case, this is a mom of a patient that we had. She's a nurse and was interested in something that was aesthetic, but also kind of user-friendly for her lifestyle, not being able to take something in and out all day long with her shift and just her lifestyle. So you can see she's got crowding, kind of flared, butterflied upper ones, lower crowding. You can see her upper right 4 is also heavily carious and non-restorable at this stage from the dentist point of view. So again, her why is because she didn't want braces. She didn't want to have to keep track of aligners. And in her particular case, her treatment plan was going to include extraction of that upper right 4 as well as the lower right 4 in order to get some symmetrical space closure and retraction in order to close that the space from that tooth that we're losing. She also has a little bit of a posterior constriction on her right side as well too. So her progress photo coming up is at 6 months. So what we did is we extracted upper right 4, lower right 4. We bond the lower and then the upper in this particular case. So at this stage, we've got pretty much all the space closure in the lower right segment. We were able to bracket and attach the upper right 1, and this is a Gen 2 case. We use some anterior bite blocks to help with those canines not having interferences. And at this stage, we're primarily working on getting the rest of the space closure in our DE wires after that. So next one is at the 14-month mark. So space closure is complete in both the upper and the lower. We have a little bit of the bite being held without biting those canines with some build-outs again. And we were able to close that space in the upper and the lower and finish her out soon after this and get her into retention. So we had extraction that we were able to close in the upper right, so to save her having to get any restored tooth as far as like an implant. We use that space to correct her crowding basically on both the upper and the lower. So yeah, she's a little propped open in this one. By the time she's done biting down, her midlines are on to the degree that we can get hers on as far as with her 2 sides. So yeah. Good. And that's the last photo for hers.
All right. Thank you so much, Dr. Horsey.
Of course.
Next man up is Dr. Scott Shorts, the inventor and creator of the Smart Wire plier that y'all love. So thank you, Dr. Scott Shorts, for everything you do behind the scenes for us. And yeah. So between Dr. Scott Shorts and Dr. Horsey, the two of them combined for almost 2,000 InBrace cases. So pretty remarkable. Thank you so much. So go ahead, Dr. Shorts, go ahead and get started. And if you don't mind, share your background. How'd you get started? How'd you become an InBrace provider?
So I started about 2017, and super excited. Patients wanted something aesthetic. Initially, I started with Incognito, did 100 cases of that, and just found it to be a little bit more technique involved. It was super expensive, and patients really weren't loving it. And one day I saw this little thread on Facebook, and Matt Wang and I started chatting, and the rest is history. You know, it's been a game changer for me in my practice. You know, I basically, every chance I get, I talk up InBrace in my practice with any and all consults. Even my staff is always talking about it to parents when they're sitting there with their kids. And so we always bring it up, and we really generate a lot of InBrace cases just by, you know, word of mouth. And I highly recommend just showing it to everybody, because it just, not everybody's going to grab on it, but that's okay. But the fact that you get known as being the person that does the inside braces, and that's what I'm known for, doing the inside braces, it's been a fantastic journey for me so far, and loving it, and also working with the internal people, trying to better the product for everyone out there all the time. And I could hopefully, we chose a couple of cases here that I could show you everything here. So,
Do it.
Sarah. So in my practice, probably I do more, almost as many teens now as adults, because everybody, once the teens start doing it, they tell all their friends, and they keep coming in wanting it more and more. So I highly recommend, don't be afraid, transitional, you know, teeth here. It's not a big deal. This kid, he's 13, came into me, and he wanted InBrace because his brother had InBrace, of course, and pretty deep bite here. Basically, he had a deciduous tooth on the upper right, which I asked for a bypass loop, which you'll see on the next next set of photos. It's basically a wire that has just a little scoop to it, so it doesn't affect the area. It allows me to still get some correction of the molar posterior there. This is basically his start. I don't bond the lower only all the time. I try to listen to the patient, hear their story, and then I choose on what to do. But a majority of the times I do start with the lower, but it really depends on what's going on with the patient. So here, basically started him up and Vincent, basically, here's his completed case. So deep bite, finished nicely. It was basically 10 visits, including the consultation, 2 wire breakages, and basically the fact that he's wearing his retainers now is a godsend, because most of my teenagers don't wear their retainers. So I really try to emphasize that with them. But here you could see he got some nice bite opening, a nice finish to a class 1. Basically took 12 months, and I don't think I could have done that with labial braces. Forget about aligners on teenagers. I don't even attempt it in my practice. And so 12 months was fantastic for me, and he was loving it. And this family has already referred at least a half a dozen people to me of his friends that are getting InBrace. So this woman, she's 55, came to me. She doesn't like the way her front teeth look, so rabbited back. Really needed to improve on the torque on the upper incisors. A lot of crowding on the lower. Get some expansion here, or arch development, as I like to call it. And so in the setup, you shouldn't worry about how much overcorrection do I put in. InBrace is fantastic at helping you do the setups if you want, and they will help you along with overcorrections. And now I know that they're starting to implement that automatically for you in the setups. So really, InBrace has come a long way since I've been with them. So don't be afraid about that. So how much overcorrection? I can't see the rest of the question there. What does it say?
Sure. It says on your younger patients, do you ever run into problems of not enough lingual surface on the lower bicuspids? If you do,
yes, sometimes I see that. And sometimes you get the bracket a little higher than I want. And so, but I have to say that breakage has been minimal. But if I do get a breakage on that, when I reposition it a little bit more gingival, so I don't really have that issue. But yes, that does occur a little bit with the eruption, a slow eruption or the small surface area. But eventually it pans out. You'll be fine. In the beginning, if you can't get a bracket on there, you could do directional wire bonding right to the tooth to help it extrude. And it really not a big deal at all. It works out fine. I really haven't had any issues with that. You want to save the questions, Matt, or you want to? I saw some questions pop up. So
yep, we have another one. How much do you overcorrect the root torque, or just plan on using SmartWire 3?
So SmartWire 3 is more right now, as it doesn't come standard in the kit. It's actually something in IR that you would have to ask for, an item request. So depending on how much torque I want, I'm not afraid to put an additional 10 degrees of additional torque in where I want, especially on a case like this. Not an issue. I'm not concerned about that because I'm seeing the patients every 10, 12 weeks. And that is not going to really affect me. You could watch it carefully. But I've never had, in the hundreds and hundreds of cases that I've done, I put even 15 degrees of extra torque in, and I've never had any problem with really an overcorrection to that degree anywhere near that. So don't be afraid to add that. But again, with adding that, you need to also add intrusion and extrusion with your torque control. So those are things that your TIS and the in-house doctors could help you do in the setup. So let's move on with this case. So I basically bonded her upper first. The reason again here is I wanted to get that torque and those uppers going as quickly as possible. So again, here, I wasn't able to get a bracket on the upper right 2, so I did directional bonding of the wire to the tooth, and that worked out well. And the following visit, after she got used to these, I bonded the lower. Again, I had a couple of teeth that was not able to. I'm going to say this is about 4 months, or basically 3 visits in here. And so I bonded the lower, and you could see the upper, how much the torque already of those upper incisors has occurred in that quick amount of time. I could not get that correction in the liners, that kind of torque correction in the liners in that short of time, or I don't feel in labial braces get up to that wire enough to get that amount of correction as well. So here, she's not biting correctly on the bottom picture, so try to ignore that. But here is where I went into a DE, where I added some space closure, rotational correction of the upper left canine, some better alignment of the lower and more leveling of lower 2 to 2. I rebonded the repositioned the lower right 3 bracket because that was so far distal in the initial setup because of where the position of the tooth was. And I find that sometimes you may have to do that if you put a bracket on with where you have limited space to do that. That's why I like to bond the wire directly to the tooth and not offset the bracket so much, where I get enough where I could put the bracket on the first time at the better position so that I get better tooth movement. So that's what I have found. All right, next slide, which I think is the finished case. Yeah, so again, got some nice correction. You can see the occlusion socked in beautifully. This case on Anne was 12 visits in my office, 1 DE, and 2 emergencies. So basically about 14 months, about 15 months total of active treatment. And she was super happy about this case. She was super happy with the result. And, you know, I was super happy with the result. I have found doing cases, I've done surgical cases, canine exposures, premolar exposures, class 2 corrections, class 3 corrections. I really find that InBrace could help me in almost any case that comes into my office now. I have no problem offering it to every patient that walks in the door. All right, next case, which is, okay, so we have this gentleman, he's 35. He came to me, he was an aligner failure case and has a significant amount of crowding on the lower and a deep bite. So I wanted to do this case non-extraction. I know that you have the lower incisor gingival concerns there, the bone, and I agree 100% with everybody on that. But looking at the Ceph and everything, I wanted to do this non-extraction, watching it carefully. And I was also using this new specialty wire, which hopefully will be coming out soon, that I helped out design. And let's see the next. Okay. So basically, the reason why I can't show you in between is because I'm not allowed to show the photos with that wire. Just so you know, I created the space for that lower incisor in 11 weeks. Okay. And so this case, as you can see over here, I did not go to the upper 7s. I went to the upper 7s later in the case on the DE, on the 1 DE. Basically, aligned everything here nicely. Again, that lower right canine, that bracket's a little offset, and I asked for a reposition in the DE to help with the rotational correction, and I also asked for some torque on that lower incisor where the gingiva is basically the same from the initial photos, which you saw, and even fitting in this tooth, you could see the nice torque control to not allow that to get progressively worse. Obviously, in the upper anterior, I'll do some enamelplasty to level out those, and maybe a little IPR between the centrals to close up that black triangle. Right. Okay. So here, he's improved a little bit, and I ordered torque, and you can see the torque on that lower incisor has improved the gingiva quite a bit. And this is where I'm at right now. Midline's a little off. We're going to start maybe a little, even though he's class 1 with the canine, I think there's a little bit of a Bolton discrepancy here. He didn't bring up the midline. His upper midline is on with his face. The lower mid is slightly off. I could do a little IPR, but there's also a little spacing on the lower, which is closing up. So that might improve the lower incisors as well. But again, here you could see the nice improvement of his deep bite again. And you could see in the upper left-hand photo where I did go to the 7s in the DE. I do not personally, I've tried, but learned from the patients not happy with going to the lower 7s. So I go buccal 6, 7. I have no problem doing that. Patients have no issues with that because you're not seeing anything. On the upper, I'll go to the 7s if I need to all day long, not a big deal, especially if I'm doing a class 2 correction, always go to my 7s on that. Okay, so this young lady, 25, I believe, came into me, 7 months, said, can you please, I'm getting married in 7 months, could you fix my teeth? So I said, no problem. We have InBrace. And I said, and if we can't completely finish you before your wedding, nobody's going to see the brackets. So you shouldn't have to worry about that. I've had many patients actually get married in InBrace coming to me where they want to get married in 3 months. And I said, I can't do that. So basically bonded her up. Again, I wanted to start with the upper first, because again, that's what most people see in the pictures. So I wanted to make sure I get that done and off for her in time. Concerned about the, following the open bite tendency, the crowding, as you can see again, couldn't even bond the wire to the tooth on the lower incisor. So basically just added a little soft flow to the locket there and let the wire work a little bit. As you can see also, I stayed on 5 to 5 here. She had nice occlusion on the 6, 7. I didn't think I needed to go there at all. So I stayed with 5 to 5 upper and lower. Basically here she's finished. Finished her complete. This is done for her wedding. Yes, I agree with the upper right lateral. This is actually after she came back from her honeymoon. This wasn't the D-bond, and she didn't wear a retainer that well, so the upper right 2 needs to be pushed out a little bit. So I made an in-house aligner, which she needed a retainer anyway to fix the little discrepancies in the upper 2 to 2. We have a Bender 2 machine, which I love to do my lower bars and sometimes upper bars. But I think she was super happy, smiled ear to ear at her wedding, and I was super happy for her.
Awesome. Any questions from the audience for Dr. Shorts? We'll wait about 5 seconds before we go to Dr. Wang.
Right.
All right. Thank you, Dr. Shorts.
No problem.
Dr. Wang, thank you so much again for joining us while you're on vacation. So nice of you. This is just one of many things she does for InBrace behind the scenes. So without further ado, here's Dr. Uni Wang.
Thank you, Matt. Hi, everybody. My name is Yuni Wang, and I have 4 cases to share with you guys. Right now, I'm an orthodontist at Amanda Gallagher Orthodontics in Maryland, and I've been doing InBrace right out of residency. I was not trained with lingual systems when I was in residency, so I started learning about InBrace when I graduated in 2020. I started with Gen 1 InBrace, went through Gen 2.1, the heavy force system, all the ups and downs with all the team members. And now we've been loving doing InBrace Gen 2.2. Mostly because InBrace can deal with all types of cases. And my recent favorites have been the ones with missing interior teeth that require Pontics or the upper 4s that are missing. Thanks to Dr. Scott Schwartz, who taught me how to make Pontics with the beautiful composite fillings. My patients have been loving them. And I also love the fact that usually with the labial systems, if we do Pontics for the missing spaces, the Pontics start turning when we are still in round wires. And with Invisalign, if we paint the Pontics, whenever patients take the aligners out, they're missing teeth. So many patients don't like them, but with InBrace, because we bond the Pontics directly to the teeth, many patients have been loving InBrace, especially with those cases. And also we feel like InBrace is also amazing at doing bonding to crowns, which are often struggles with the labial systems too. And Dr. Schwartz already mentioned that it's also great for like big events and weddings, brides get married in them. And also one thing that I love about InBrace is that I don't have to rely on patient compliance, help save doctor chair time, and also especially for many those of you guys who are thinking about doing InBrace, it's a great differentiator for building your practice, especially for new startups. And also, the one most important thing that I love about InBrace is the support system that we have, especially Matt, Tara, and also Aaron, who is our TIS. All of our team members love working with Aaron. So those are just few of the many things that we love with InBrace. So I'm going to start with the first two cases, and those are going to be class 3 cases with shallow bite. So this is Tristan. He is a 16-year-old high school junior student. His chief complaint here was the upper right toe alignment. And he's a swimmer, and he didn't want to deal with the liners in and out, did not want braces as a junior in high school. So he wanted InBrace. Also, the parents did not think he was going to be compliant with the liners. So this is when we first bonded his upper arch. And as you can see, we have some alignment that we have to work on for his upper arch as well as the lower, and we have a crossbite on the upper twos. We have the progress photos for his treatment. This is about 4 months with Tristan in treatment. And as you can see here, the crossbite that was present on the upper twos have already been corrected. We ran some nighttime class 3 elastics from the upper 6s to lower 4s. And as you can see here, his main chief complaint that was upper right 2 has already been addressed. So he's been a pretty happy patient here. One special thing about this patient is that because him being a teenager patient, he had 3 ER visits. I wish that Tristan was as compliant as Dr. Sarah's patient who didn't break any brackets as a teenager patient, but he had 3 broken bracket issues. So he came in, but for those appointments, what we did to be efficient with our chair time was that we took care of our adjustment visits whenever he presented for his emergency visits. So we didn't have to waste too much time whenever he had to present to our office to get those brackets fixed. And this is only when he was 4 months into treatment. I think this is pretty amazing result considering it's only 4 months in. I don't think I could have done this with the labial system nor with the liners, especially with the compliant issues. So a similar case here, class 3 tendency, shallow bite, also crossbite present on the upper twos and also the canine area too. This is 37-year-old Joel patient. He's an engineer. He didn't want to do any braces, didn't want to wear the liners. So similar reasons as Tristan. So this is about 6 months into treatment. This patient did not want to do any IPRs on the lower, so I wasn't able to do that. But instead what we did was controlling the vertical dimension so that the bite doesn't open with the presence of the lower crowding. So what I had to do when I set up the smile design was building in some extra intrusion to the posteriors and also a little more extrusion to the upper 2 to 2 area. But looking back, I probably would have done a little more extrusion to the upper 2 to 2 for smile arc. That's something I would have done differently for this case. But considering that I couldn't really use any IPRs here, and also with the presence of the initial crossbite, I think with 6 months progress, I think this is pretty good result. Again, I don't think I could have really done it with the labial braces, and also a patient was not open to those systems at all. So again, patient has been a big fan of InBrace ever since day one. And I guess this is the most recent progress photos that I have for Joel. So here the bite has improved even more, and the bite did not open at all. And so one thing that I'd be doing going forward would be to improving the upper twos alignment and also their vertical positions a little more. That's what I'll be doing for Joel and the digital enhancement. And now moving on to spacing cases, which I feel like is also a great system, great case selection for those of you who are thinking about starting InBrace, because spacing cases, I feel like gives our patients the fastest result. And many of the spacing cases start showing good progress about 3-4 months in. So many patients are very satisfied with the result, and then they become our greatest referral sources. So this is Miriam. So her chief complaint was the spacing between the lower 1-to-1 area and also the upper left distal to the laterals. So here, this is about her 6 month, I think this was 5-6 months progress here. As you can see, her chief complaint, which was the spacing between the lower 1-2 area, has already been fully closed. And the posterior bite has not been compromised at all. And also the spacing distal to the upper left 2 has fully closed. And she's happy with the alignment and the space closure. And again, she has been one of our biggest referral sources because she's just so happy with the results that she is seeing at the moment. So she's about to be scanned for her DE wire. It should be just a very minor improvement with the DE, and I'm hoping to finish her within about 10 to 12 months of treatment total for her. And a similar case, also another spacing case. This is Ashley. She's a 37-year-old female. She's the mom. She didn't want to deal with wearing the liners, and also did not want labial braces because she was going to be in her friend's wedding that was coming up. Probably, I think she had that wedding about 6 months into treatment. So she only wanted to do InBrace for her treatment. So here, this is about her 4 months progress into treatment. As you can see, the spaces that was her main complaint has almost all like closed. And she's already very happy. She's excited to go to the wedding. Also another great case that many patients love with InBrace is the spacing case. And she actually did finish her treatment. So I believe I have a final photo here. So this is when she finished the treatment. All the spaces have fully closed. I wanted to give her upper 2-2 and the lower 3-3 lingual fixed retainers. We were not able to do so because her gums are a little bit puffy on the day of the event. So that's something that we did do about a few weeks after she finished her treatment. But again, she's been extremely happy with the result, and she's been telling everybody about InBrace and her friends and family members that she refers to our office. So again, another great case selection for starting InBrace would be, I think, would be a spacing case.
Awesome. Thank you, Dr. Uni. Any questions? I know you got a lot of people saying, wow, great cases, but any questions from the field? We'll give it 5 seconds before we pop over to Dr. Shulsky. I know that if you saw her present on Tuesday, she was just amazing. So you guys are all in for a treat. All right. So without further ado, Dr. Shulsky, take it away.
Wait,
Thanks.
sorry, can I ask a question unmuted?
Oh, yes, of course.
Sorry. Hi, Dr. Wong. Those are great cases. When you're doing your stage space closure, when you do like DE wires, so you get into like SmartWire 2, do you put in SmartWire 1 or put in the next SmartWire 2 when you're staging the space closure?
I think that's a great question. Actually, that's actually very similar to what I asked Dr. Horsey on Tuesday when he had the spacing case that he presented. For the amount of space that Ashley had, that was less than 3 millimeters. I didn't have to stage space closure, so we fully closed all the spaces from the initial setup, and then the DE only had to take care of mild fine-tuning movements. So whenever I only do fine-tuning movements with DE, I go straight to the SmartWire 2 DE, and I just skip number 1 so that I can get the patients done within
Okay, that's what I've been doing as well, but sometimes the wires break, so I just didn't know if maybe I was doing it incorrectly. Thank you.
Yeah, no problem. And hey, trust me, it happens to me too. Wires can break. So which is why I try to get it in with number 2, because I also have noticed that if I go back to number 1 after doing regular, like initial SmartWire 2, I feel like there's a little play in the bracket slot with the clip of the brackets that I feel. So I like to go to number 2 right away.
Awesome. Thank you so much.
Yeah, thank you.
All right. Sounds good. All right, Dr. Shulsky.
Hi, I'm Jenny Shulsky. Nice to see everybody here. So I started with InBrace right out of residency, practicing in DC. I joined a practice in Northern Virginia, took over for a retiring orthodontist, and nobody knew InBrace. They didn't want to incorporate it. They were, the staff from the retiring orthodontist. And if anybody's out there, contemplating whether or not they can incorporate InBrace into their practice, I promise you can. They are wonderful at not only teaching you as a doctor how to use it, but they will come to your practice, teach your staff. We've recently sent all of our assistants out to Texas to be trained, and my assistants went from, I don't want to do any InBrace, to this week fighting over who gets to do the InBrace case. So, I mean, it's amazing. It empowers your assistants. They get to do a lot of stuff chairside, so they feel like, you know, they have a real integral role in the practice. So I can't say enough about InBrace. I promise you, if you're scared, just take a stab at it. Okay, so I'll get started. So I am going to talk about a case that specifically addresses rotations. So this is my patient, Miss Duria, and I apologize if any pictures are not clear. We were transitioning from trying to take pictures with iPhones, which did not work. So if there are any pictures where I didn't like, I took screenshots of the scanned images. So here she is with her initial case photos. So Miss Duria presented, she's 52-year-old female, mom to 3 teenage girls, no history of ortho, and she was referred to me from the general dentist to address increasing recessions around her canine due to excessive rotations of the canines and her heavy class 2 malocclusion. So Miss Duria stated she was actually generally happy with her smile, and she was literally only there because her general dentist was concerned about the recession. And so here's just taking a closer look, you know, almost 90-degree rotations of the canines. Again, she did present with lower proclination of the lower incisors with spacing. And so then you can go to the next slide. And so here she is, a better look at her class 2 with the canine rotation. And then you can see the proclination of the lower incisors. So here's a better look at her canine with the periodontal loss in her upper canines. And you can see that the lateral force of the canine from her bite is just increasing that recession, and it's gotten worse within the past 5 years. You can go to the next slide. And so here's my dilemma. You know, how do I treat her efficiently and effectively as quickly as I can without damaging or further damaging that periodontal tissue? She states she doesn't want braces. She's mom to 3 teenage girls. She's not aesthetically driven. She likes her smile. I don't think clear aligners are the option for her. Not to mention, I don't really feel that canine rotations are effectively treated with clear aligners. So for me, you can go to the next slide. We chose InBrace for her. Her lower arch was bonded first, December of 22. Upper arch was bonded 4 weeks later, January 2023. And if I had to do this case a little differently, I probably would have bonded her upper first because that was, you know, the main concern. Because of the rotations, we weren't able to include the brackets in the IDB tray. So we directly bonded the wire to the canines, and this is her at her initial visit. And so before I go further with, you know, what she turned out and how her treatment went, I just kind of want to go over, you know, why InBrace? Why did we choose InBrace, and why do I continue to choose InBrace for these cases? I can't emphasize enough rotations of the canines, rotations of the lateral incisors, and I've taken all the fellowship Invisalign courses everybody here has taken. I've used every attachment, and it's just the efficiency of InBrace compared to clear aligner therapy is just unsurpassable. So just as a comparison case, here's a case that I bring up with clear aligners, and this is Mr. S, and this is going to be an extreme case. So I was lucky enough to take over for a retiring orthodontist, and this was one of his cases that I kind of walked into. When I came into the practice in 2022, Mr. S had been in clear aligner therapy for 4 years, specifically trying to address canine rotations. So this is a little bit different of a case because this is lower canine rotations, but he did only want canine rotations addressed with lower crowding. So the patient came in, he was referred to by the dentist. They only wanted lower canine rotations taken care of and lower crowding taken care of. They did not ask for the diastomy to be closed, which would have made the case much more difficult. So the clear aligner case began 11/13 in 2018 by the retiring orthodontist. So the dates are blocked out, but I'm just going to go through. So here is you saw where he presented. This was a scan of 2019. The middle slide is a scan of July 2020. And then the last slide, the last picture is the last picture I have in January of 2024. The space was created early. Every single attachment that you can imagine was done on these canines. And, you know, I went over this case time and time again, asking myself, are these canines ankylosed? You know, what's going on here? How could this happen? But the canines did move. They just were not moving efficiently at all. So what happened to Mr. S? This is his last visit in January. This was a case where we had a patient cancellation. I was giving him his next set of aligners, and I just begged him, please let me put braces on. You know, had I had more time, I would have scanned him for InBrace, and I'm hoping to get InBrace possibly on the top. So we shall see. But ultimately, I just wanted to share this case because it's very frustrating sometimes with aligners. So back to Miss Duria, direct bonded her SmartWire 1 in January 23. And so here's a progress photo in August of 23, literally 7 months in. And so to the left, the slide is her initial, and then here's a comparison. I was able to place a direct bonded bracket in August, 7 months in. And honestly, at this point, she has 90% derotation taken care of. I know I bring out the last slide, but almost 5 years later, and I did not have that with the last gentleman. So very, very happy with InBrace. And so the DE was submitted in September of 23, and it was specifically just to repo the upper threes because I had to direct bond them. So I wanted to make sure that they were correctly placed. One thing that I did do is I placed posterior bite turbos, and that did intrude and created somewhat of a bite opening. So the DE was literally to settle the bite and to repo the upper threes. And this picture right here is essentially where she's at today. So she's had full derotation of the canines, and she's had complete bite settling. So the goals of treatment was literally to address canine rotations, improve class 2, and we did not make the overjet worse. Okay, so lessons learned here. No treatment modality is at all better than any other one. But honestly, certain modalities are more efficient. So for me, in my experience, honestly, addressing canine rotations they're just more efficient. InBrace, for me, works over clear aligner therapy. Thanks, guys.
Thank you. Thank you so much for that. That was such a good presentation. Any questions? We got 5 seconds for any questions with Dr. Shulsky. I'm not sure. Is InBrace good for rotations? I didn't really get that message.
Yes, it's amazing.
All right. Who's up next, Dr. Tara?
We've got Dr. Glasser, St. Martin,
Okay.
Jessica, go
All right.
ahead.
So if you've never heard Dr. Jessica present, she is amazing. She's been with us for how long now, Dr. Glauser?
I started, my first cases were bonded October 2022.
Nice.
So it's been a while now. I mean, I think I've done like 60 cases plus at this point. So more than a minute. But yeah, so I practiced in the Phoenix Valley in Arizona. I was actually the first InBrace provider in Arizona, which is like very exciting for me. I went to dental school with Dr. Tara and Dr. Lee, not Bobby, right? He doesn't go by Bobby anymore. But yeah, so they were really cool ortho residents while I was like a little lowly dental student, and were, you know, telling me about this cool lingual braces system. And so as soon as I got out of school in 2021 and started practicing in the Valley, definitely onboard that into my practice. It's a good differentiator for me. And like we've discussed, there's just certain cases where it's a better lifestyle fit for the patient, but also that the mechanics work a little bit better, or a little bit more efficient. And you can get pretty amazing results with decreased treatment time with InBrace compared to like clear aligners or even traditional braces. So we can get going on my cases. I'm doing 2 like trickier ones. They're extremely vertical patients. And then we'll go over like kind of like why we picked InBrace for them and kind of how things are going so far. So this is Jesse. He is a 24-year-old construction worker. He did not want to do braces because he's an adult. His girlfriend thought it wouldn't look cool. He also knew he would not be compliant with aligners. He thought it would be gross to take them in and out while he's working. Like, he primarily does like carpentry, so he's like dirty and very busy during the day. So we chose braces for him. He's very vertical and obviously has that pretty big open bite. His wisdom teeth are erupted. So with InBrace, I treatment planned for him to get the wisdom teeth extracted and then use some like new loop mechanics, because InBrace has the loops, so you can definitely build in all that intrusion to help swing the upper teeth up into those extraction spaces and close the bite pretty efficiently. So we'll see how that's been going so far for him. So this was his, so that was how he looked when we did the fitting in November. Well, so that we skipped one appointment with photos, but so he got the braces on in like the end of summer, and then we got up to Smart Wire 3 by November. In November, he had his wisdom teeth extracted, and then this is 6 weeks later. All that bite closing, like that from where he presented in those last photos to these photos is 6 weeks later. Just with the loop mechanics and intrusion, and just wearing vertical class 2 like elastics. So it's pretty amazing results for him. So I at this point scanned for DE, and then we're just gonna address more of the alignment, kind of more bite correction, and then fine tune his case, where that vertical of the case with braces would have definitely taken me more than a year, and we're gonna have that whole case done in less than a year. This is my next patient, Noah. He is a teenager. He's 18, where he just turned 18. He was 17 when we put his InBrace on. He's also very vertical, very class 3, like pretty maxillary retrusive. He didn't want braces. He didn't want to wear aligners. He specifically found our practice because we were an InBrace provider. He had seen it online, seen some ads on social media, and thought that was what he would want to have. So he came in, and I did upper lower 7 to 7 with him because I was really worried about the vertical and with things opening up. So this was him the 4 months after bonding. I had him in kind of moderate to heavy class 3 elastics kind of right away. So you can see I kind of really did over extrude some things. There's leveling isn't quite right, but we were able to jump his bite pretty quickly within the first 4 months. And at this point, he's in Smart Wire 3, and I scanned for DE. And we're going to finish up the leveling, keep correcting the like alignment issues, and then the bite. But again, for him, it was less than 6 months. The bite was just like corrected. I was able to control the vertical very well. And he was also very crowded on the bottom, and we were able to resolve all that crowding without pushing him into even worse underbite and decompensating him, because he was very already like class 3 compensated. So we were able to like have the torque control, correct everything without kind of making his bite worse before we made it better. And that's the kind of main thing I wanted to highlight with this case, is while like, yes, the leveling is not perfect by any means, but we were able to kind of correct things and make it look better the entire time, instead of, oh no, we have to correct the alignment. Okay, like it's going to look a lot worse and it's going to take more time before we're able to get these like amazing results. And the patients are super happy. Any questions with these two? They're both like very vertical cases, kind of a little bit more ambitious of InBrace cases. They're probably, I mean, I didn't tackle this tricky of cases until I've been doing InBrace for like a good 8 or 9 months. But I mean, if you're the orthodontist, like their teeth, you know how to move teeth. Any case in my office is an InBrace case, and if it's a better fit for the mechanics you're using, a better fit for the patient. Yeah, I think anything is a possibility, and we're super happy, and the patients are super happy.
Awesome. Thank you, Dr. Glauser. All right. There
was one question really quick, Matt. On the open bite case, did you say you got intrusion of the molars?
Yes. So in Jesse's case, so the two that were the case before this case, I did build like over intrusion of those molars to like push the teeth up. I built distalization and intrusion because he was a little bit class 2. And then I didn't put bite turbos on the posterior on the bottom, which I could have. But I was really relying on those loops to intrude the molars up into the extraction sockets, like where the set 8s were. And then I also did get some extrusion of the anterior. I should have given you guys the face photos. But it was like 50-50 extrusion of the anterior and intrusion of the posterior within that 6-week window of when we closed like that crazy open bite.
All right. Well, thank you so much, Dr. Glauser. Love that. Every case is an InBrace case in your office. Yeah, thank you so much. We'll start with Dr. Quigley, and then we'll go to Dr. Sodi. Okay.
Hi, I'm Suzanne Quigley. I'm a solo practitioner in Red Bank, New Jersey, and I started InBrace right when Gen 1 became Gen 2 or turned into Gen 2. I did the didactic course on Gen 1, and then the reps came to the office and said, we're launching Gen 2 next week. So if you scan any cases, it's going to be Gen 2. So I had to kind of scramble to get up to speed with Gen 2. So I'm relatively new to this, and this is a case, it's a deep bite with some upper spacing. So she's a 26-year-old nanny, and she had ortho as a teenager, didn't wear a retainer, and she knew with the 3 kids she nannies, she wasn't going to wear the aligners. So she specifically came to my office looking for InBrace, found me on the provider portal, the website as a provider, and I bonded upper and lower initially right at the, at the first visit. Did the ferment on the upper 2-2. We had a little bit of breakage. She had some interproximal loop food impaction areas in the upper 4 or 5 areas. So I had to slow down on the take the wire out for a little bit. So I didn't have smart wire 1 and 2 in at the same time on the upper and lower. But the top picture was at the initial her consultation, and she wound up, that was in July, and when we started, that second picture was in, I think that was 8 weeks later, believe it or not. And then the last picture that was her DE in the beginning of February. I wound up doing a little enameloplasty on the upper ones, the torque on the upper left 2. I should have probably programmed more torque into that torque correction on the upper left 2. But the bite opening was amazing in this case. I would have struggled with this for much longer with aligners in an adult. And what you can't appreciate from this picture is there's a little bit of excess overjet she wasn't crazy about. So I'm going to do a little IPR on her upper ones, just maybe slight bit on mesial distal of upper ones to reduce the overjet a bit, but she's super happy at this point. And she's like, I'm happy where it is. If you think this could be better, go for it. So I'm putting in the DE, I think, next week. But that was a little over 6 months of deep bite correction on her. So I was super impressed with that. So awesome. Easy case, but one of my first ones.
They're great. Thank you so much, Dr. Quigley. All right. Thank you so much. We're going to go to Dr. Sodi. Thank you so much for being patient. You were the first person on, the second to last. So thank you so much for being patient. Before you go and show your case, if you don't mind, could you just share what you shared with us, as we were getting ready for this call about marketing and what InBrace has done for your practice, please? That was amazing.
Sure. I would. Hi, everyone. I'm Dr. Sodi. I practice here a little west of Dallas in Irving, Texas. I bought a practice about 2 years ago, 2.5 years ago now. This is going into a third year. And Dallas, we all know, very competitive market like many other markets. So I did not get the luxury of getting too many referrals. So I relied heavily on direct-to-consumer marketing. And, I started InBrace pretty fairly quickly getting my practice in, just because, my initial thoughts were a differentiating factor. Nobody else around me was doing it. So I wanted to do it, and I wanted to present that idea. And honestly, just kind of use that more or so, just to kind of do a few cases here and there, but nothing much. And but recently, we've been doing our own social media marketing, and in December, we kind of try to do our social media ads catered or centered around InBrace. So we made InBrace as one of the main things that we're like, okay, this is InBrace and this is what we want to introduce to everybody. And that has been one of our best sellers, sort of like best set of ads that have been working really well for us. To be honest, like we were getting like great leads. Like if I give you like an idea or an estimate, like almost like 20 leads a day. Like over the weekend, we would get like 30 leads. Like it was crazy amount. Now I do understand everybody who has dealt with social media marketing would know this, like not all leads are good leads, and not everything kind of converts into, the cases. But we had almost, out of those leads, like we had special people who kind of work and set up these calls and stuff. I literally had a day with consults, full of consults. Every consult patient came in asking for InBrace. So we saw an ad about InBrace. I want to know about InBrace. I want to know about InBrace. I've had Invisalign. I've had aligners. I've had braces before, or I do not want braces. I do not want aligners, and we want to know what this InBrace is. Are we candidate for InBrace? So I have been one of those very passive kind of people. I would submit. I was telling them I would submit like one or maybe like 2 cases over a quarter, not so many. I was actually just checking before this call. Overall, in these like the past 2.5 years, I've only submitted 35 cases to InBrace. 30, and out of that 35 cases, 15 have been approved or have been within this Jan and Feb, within this quarter. Like, and this is all because of that marketing that we've done. And that's what I kind of wanted to emphasize as well. Like, yes, we want to stand out, but how are we standing out, right? Like, you have to go in, you have to kind of dabble into this and like do more of it, but also show people around that, hey, this is what you're providing. And so that's been really impressive for us, like those, and now, getting back into cases, but like I'm happy to answer. I know some questions coming up regarding marketing, and I'm happy to answer any of questions related to that. Like that's something that has been helping us. But we can get into the cases too. In my cases, I mean, I've seen like some crazy cases that all of y'all have shown, like some really, really good cases. But I have, again, I've been like one of those proponents where I'm like, okay, you want InBrace, you're getting it, and I'm going to make it work. Like whether I'm going to use some auxiliaries with it, whether I'm going to do, partial like labial braces or whatever with it, but I'm going to make it work to make sure that my patient's happy. Like that's one of my goals in practice. Like whatever patient comes in, I'm catering to their needs. Like I'm kind of new, and it might not be a universal kind of, thing that, okay, like this is like, I know, and I completely respect this. Like there are orthodontists who would not do any or not try any of the modalities if they feel like one certain modality is better. Like, but I'm like, okay, I'm going to listen to my client. I'm going to listen to what my patient's asking. Like if the patient's coming in asking for a more discreet option and they want something more hands-off, I'm giving them InBrace. I'm going to dabble it, whether it's like extraction cases. I've done extraction case. I've done like, I don't hesitate of diving into, and I feel like looking at y'all's cases that y'all are like sharing, I think you can achieve everything with InBrace. Like I don't see a difference in a different modality. It's like just another tool in our box. So, but yeah. So this is one of those cases, actually. This is a very interesting story about her. She's a 34-year-old female, and she has been raised in foster care all her life and did not get a chance to take care of her teeth like at all and growing up. And now, she's actually working a professional. So she's like, now I think she's into law or some, a pretty good professional field. And she wanted to address this issue of like severe crowding. And I don't know if you guys can appreciate or not, but she has like a posterior crossbite as well. She's got midline deviation. She's class 2 on the right side, and very, very good amount of crowding. But this was one of her things. Like she was like, I want discrete option. I do not want to have braces. And she wasn't very sure if she would do something like aligners. And I did not, to be honest, like I did not even offer it to her because, again, we've talked about rotations, and rotations being not a very strong suit for Invisalign or any other kind of clear aligners. And I always feel like braces or InBrace does so much well for these kind of crowded cases. And this transition, this first photo, between the first photo and the next that you see, which is my wow picture here, it's only 3 months. It is just one wire. And we had 2 appointments, and just because that one appointment was because there was a broken bracket and that happened. But this is just one, like if that SOS was not there, like this is a really, really remarkable change. And you could totally see this person who has like completely neglected herself all her life, kind of coming back to life to herself. Like she is taking care of herself and she's seeing this amazing changes happening so fast that she's like, okay, let's do it. Like, you know, like she's really happy. She's opening up with us as well. I do have some buttons going around and I'm planning to do some rubber bands, and she is wearing the rubber bands. I did tell her like we have the expectations very, very minimal. So I've told her that, okay, posterior crossbite may not correct, your class 2 may not correct, fully correct, but I'll try to minimize as much overjet, and your midlines may never correct completely as well because of that. But that's been something that we're dealing with. I mean, the expectations have been set already, but I do feel like the amount of result, the correction that she's going to get will be amazing. And then we can move on to the next case. Now, this is again a very interesting case. Like this is a 33-year-old actually. He is a professional working in a really good company, but he literally came into the office, and you know, because of that social media marketing that I do get people who have never seen dentists in years. You know, that happens. Like the people, they're coming in and because they're not referred by dentists, they want to their teeth straightened, but they have never been to a dental office in a long, long time. And this guy, even though money is not a concern, like he's a good working professional, but he literally told me the day I was off of my parents' dental insurance, I have not stepped foot into a dental office. And he's 33, so probably the last time he was to a dentist was probably 18 years or maybe 26, depending upon when. But he did say close to 10 years. So severe lower incisor recession, we could totally see. And I don't know if you have like a shot of the occlusal shot of the lower. I don't think I have that in that. But you can't. There's literally an incisor right behind that lower right too, which you cannot see. Like there was severe crowding, a lot of severe recession in the lower incisors. I did take one incisor out for him, like the lingually displaced incisor was extracted, but the amount of correction we achieved. So in between these 2 photos, again, 3 months, 1 wire change, 2 appointments, like literally super fast, super efficient. I mean, you can totally see. So the upper was actually bonded very recently. So the last time he was with us was in November. That is when we did the upper fitting for him. And then I did see him in January when he came back for his appointment, and that's when the picture was taken. You can already see the correction happening, but this is just SmartWire 1. This is not, we're not into SmartWire 2 yet. And this photo, the second photo, I apologize, it's not the very good photo, just show the amount of recession improvement, but we've had like really good improvement of the soft tissue response has been really good for this case. So he's ecstatic, he's really happy, and he's like, obviously, again, once they start taking care of the teeth, they start taking care of everything in their life, right? Like he's going back to the dentist, he's keeping up his hygiene, everything is going great for him. And my last case here is this is generalized spacing case. Again, this is a 25-year-old female. She, you know, spacing was one of the issues. She also comes from the similar kind of background where she's probably nobody in the family has ever taken care of the teeth, and not even been to the dentist before, and now she wants to take care of herself. So it's really amazing to see these people kind of stepping up for themselves. And all the spaces at this point have been closed, but my biggest, the thing that I really like is, like, you know, the control and the tipping, you know, the overcorrections that you can add in to make sure that the spaces are getting closed, the bite is not deepening, and you're not getting like these severe like tippings. that you have to like keep on correcting later on. So I mean, we definitely had to do like a DE for this to kind of get a little bit more correction done. But pretty much, I mean, she's happy. She's ready to be done. Like I've had people come in back after one visit and ask me, "Oh, am I done? Can I take this off?" So yep, these were my cases. I don't want to take too much time. I know that we're kind of missing out. So I just wanted to answer these two questions that people ask, like which platform do you advertise on? It's mainly TikTok was a big one for us before. TikTok has changed its kind of algorithms. So now we're back on Instagram and Facebook, but those are the main ones that we work, these three ones. And which online marketing company we do not work with any online, it is itself. Me and my husband, we're a team together. My husband's kind of learned marketing, so we do it ourselves. So that kind of answers.
All right, but last but certainly not least, coming all the way from DC, it's Dr. Mimi Nguyen. Thank you so much for staying on late. Sorry,
Yes, yes. Thank you. I'm gonna make it short and sweet. So this is David, and he's 45. I apologize, my photo, his bite, he did not bite down all the way, but he's 100% deep bite. And this case with Gen 1 took me about 27 months, but I think in Gen 2 would have been or would be much more efficient. But we did bite opening and crowding, unraveling, and prepared this, he was going to get implants. That's what his dentist referred him for. And we were able to do it without any extraction and without any auxiliaries. So that was the nice plus with InBrace. The only downside was the hygiene. I felt like I was his nagging mother every time he came in, because it was, with the crowding, it was really hard for him to keep the lower anteriors, especially the lingual of it, clean, so that we would have a clean field to work with. But we made it through, and we got more than bite opening than I expected. So if we go to the final, so he's done, ready for his implants, and really it was so simple. No, I shouldn't say simple, but much easier than if it was with the labial, compared to doing labial braces. Okay, we can go to the next one. So this is my case that's in treatment right now. I wanted to show it because he is an impacted, bilateral impacted canines and deep bite. And so we're just about 12, 14 months in, and his deep bite's corrected. The exposure was done, and we're in the process of bringing those canines into place. And I also use auxiliaries on the buccal, on the labial, because I just wanted to be able to really open space and have the flexibility to bring those canines in using both the lingual and the buccal wires if I needed to. So we're just right in the middle with Philip, and everything's working out well.
All right. Well, thank you, Dr. Mimi. I know you've been, I remember talking to you for like 3 years before you became an InBrace provider. So sounds like you love it now, and so nice to see you on a webinar again. Thank you guys so much for being on the call today. But hey, everyone, there's been so much good news about InBrace. Please don't make InBrace the best kept secret in orthodontics. We're counting on you to get the word out. So please post these cases that you just shared, post it on the ortho forums, post it on InGroup, so that we can continue to help InBrace Nation and get them comfortable. If you have a friend that is on the fence, thinking about getting InBrace, starting InBrace, call them, tell them not to wait any longer. So thank you so much. And we'll do this again soon. Thank you guys. Good night.